the lack of precision in identifying infections that are causing chronic problems like interstitial cystitis, chronic bladder infections, prostate infections, chronic sinus infections, and other diseases. That causes mistreatment, the wrong antibiotics to be used, and ongoing suffering where people get better for a little while, then they get worse again, and this unending cycle that has not traditionally been addressed well with laboratory testing techniques until now. There have been recent developments in molecular identification of pathogens that are giving people and clinicians the answers they need to finally heal from chronic or life-threatening infections. I'm really excited because today I've got the CEO of one of these leading companies, if not the leading company in the clinical diagnostic arena for identifying at a very precise level of detail which infections are causing these chronic issues, so that people can and clinicians can have the results to finally get the relief they need. So it's MicroGen DX CEO Rick Martin. He's going to talk to us today about those infections and many more. Thanks for coming on.
Oh, thank you. Appreciate the opportunity.
So what was the need? MicroGen DX is a company that I became familiar with at a conference recently where I was speaking and I met some of your staff, and I was just blown away by the reports they showed me, the technology they shared with me, and I got excited. I wanted to share this with my listeners because I know clinically over the years I've had patients who have come in with chronic infections, chronic recurrent infections, and it is like chasing a ghost. Sometimes it's hard that they get better for a little while, then they get worse. You send samples out to the lab. They aren't specific enough. It's not sensitive enough to really hone in and identify what the problem is. And a lot of people are struggling with this. So talk to us a little bit about MicroGen DX, what makes you guys different, and how it can benefit patients and clinicians.
So yeah, basically we're a high complexity lab, and our role is detecting microbes, bacteria, fungus, some viruses, and rather than growing microorganisms, which is what medicine has relied on, people get an infection, they feel miserable, whether it's a urinary tract or sinus, they go to their doctor, they almost want an antibiotic without understanding that, well, to prescribe the antibiotic, they need to know exactly what type of microbe, bacteria, or fungus is causing your infection so they can put you on the right antibiotic. And the way they've done that through hundreds of years is literally to grow them in petri dishes. And what we now know is many of these microbes don't readily grow in petri dishes. So your doctor will get back a report that says mixed flora, or it might identify a species that's the wrong species that might not be the most abundant or dominant. And so they give you the antibiotic, as you were stating earlier. And then if it's wrong, then you still feel miserable. So rather than growing it, we can take the DNA from the bacteria or fungus that's in the sample. So if it's urine or it's mucus from your sinuses, we can literally extract. Essentially, it's taking the microbial DNA out, and we can match it to a known database of, just like I have my own unique DNA, you have your own unique DNA. Everybody has their own unique DNA. And I use the analogy of the crime scene. So if they're at a crime scene, they're collecting DNA, they take the DNA and they take it back to the lab, and they essentially have to match it to a database of DNA. If your DNA is in the database, then they can match the DNA collected at the crime scene and say, aha, you were there. It's essentially the same concept with microbes now. And so why have we been different? Well, the barrier to this technology was it was really expensive to do. And so, you'd send a sample off to a university laboratory, and first of all, they'd take a month to give you results back, which is not very helpful. So physicians aren't going to use a technology that takes a month to give you an answer. So we've been able to get the results down to 3.5 days, and we're about ready to get it down to about 2.5 days with a new sequencing platform. The other barrier was cost. The market wants to price these tests very high. I mean, sequencing is used as a common diagnostic tool for cancer diagnostics, and those cancer tests are $3,000 to $4,000 a sample. And so I've really kind of irritated the industry by pricing it very low, which I don't have a problem with because I want to make it readily available to patients. And I don't want cost to be the barrier for why patients don't have access to this. And what makes MicroGen have the ability to get the price point down is because we do a lot of samples. So the volume of samples you process, the more samples you process, the lower your price point. Essentially, the sequencing machines are expensive. The flow cells that you use, if you only have a couple samples on there, it would be thousands of dollars per sample. The more samples you load on the flow cells, you can get your price point low. And frankly, again, I mean, I'm not greedy. I want to see this. I want to take away the objection of cost. And so we price it to patients if their insurance doesn't cover it at $249. So that those two things, primary things, cost and time to deliver results make us different. Nobody else is really doing it as fast or that price point. But I think equally important, we've invested significantly in published data, published studies because medicine is difficult to change. Doctors will not change easily. They go through years of training and they learn their diagnostic approaches, their treatment approaches, their protocols, and getting them to change takes a lot of evidence, and it should be that way. Evidence-based medicine, I firmly believe that that's the way it should be. And so we have invested significantly to do a lot of studies. We have more than 100 now. So there's really no lab in our space that has devoted that much to doing research to prove utility. And I do that mainly too because I don't like to lose a debate with somebody. If someone challenges me and
I
says,
love that.
cultures are better, I'm like, oh yeah, well, I'm going to prove to you the opposite. I mean, I did that in urinary tract infections when physicians challenged me and said, show me evidence that your test is going to result in a better outcome than if I use standard culture techniques. So we did that. We published the first randomized controlled trial comparing traditional cultures with our method. We have done countless other studies since then, and not only in urology. And I just left New Orleans for a major ENT meeting or rhinology meeting called COSM. We had two presentations, one from Mass General at Harvard, Dr. Stella Lee, who's one of the top national opinion leaders treating rhinosinusitis. And she has been doing a study showing comparing our technology versus culture technique and showed at the meeting that our NGS technology resulted in patients getting the right antibiotics and reducing their symptom scores faster and better than the standard of care of cultures.
So in the world of immunology and clinical medicine, when you're talking about culturing out bacteria, for example, as you said, we'll send a sample out to the lab, whether it's sputum from the mouth, or a swab from a nasal swab, or a vaginal swab, or urine sample. I even saw on your result on your website a semen sample for chronic prostate infections.
Yeah.
Then it gets cultured out. They get put on literally on these round circle, these plates with a growth medium on them. And then it takes several days to grow it out. And then they have to be identified microscopically. And then different antibiotics are put in these plates that these organisms have grown on, and they then see which antibiotics kill those bacteria.
Right.
And then that's the sensitivity part of the. I want to fill the listener in case they're not familiar with all the steps. So you've got the culture part where we're growing it out, and then the sensitivity part where they're then identifying what antibiotics the organism is sensitive to that will kill it. Right. And that is what takes so much time in that process that your technology is cutting it out. Then in medicine and in research, there is another variable we haven't talked about, which is called the specificity and sensitivity. So how specific is a test for determining in this case, the organism? Does it detect the correct organism 80%, 70%, 90% of the time? So how specific is it? And then how sensitive is it? Over X number of samples, is it going to detect the right organism? What percentage of the time will it actually detect the right organism? So if I made any mistakes, any of that description, please correct me. You know much more than I do. But this is leading me to the question of, can you share them, your testing technology, the results in terms of the specificity, how specific it is, and sensitive it is for detecting the infectious organisms compared to that traditional culture and sensitivity?
Yeah. Yes, we've done sensitivity specificity analysis in a number of our papers. We did that in samples from synovial fluid samples from infected knees. So you get your knee replaced, and all of a sudden you're dealing with an infection in your knee. Cultures have been the standard of care there, but the culture sensitivity is about 50%. It varies between 50 and 65%.
So
Our
just to let people know what that means, basically it's a coin toss whether or
Yeah.
not they're going to give you the right antibiotic.
Yeah, yeah,
Okay.
yeah. And in urology, I've traveled around the nation, spoken to most urologists now move into these massive urology groups. They're part of a consortium called LUGPA, Large Urology Group Practices. They've done that mainly because of insurance and payers, and they get more power negotiating when there's more of them. But these large urology groups, I've given talks to many of them. And I always ask the question when I start, what is your culture negative rate for urinary tract infections? And I always hear between 40 and 60% of the time,
So that means 40, 60% of the times they're not detecting any organism,
anything,
but it's still
anything.
there.
Yeah, yeah. There's really no debate, and the molecular is far more sensitive. The specificity is the issue because then we will find more than culture methods. The question is, okay, what we find, is that what's creating the pathogenic role? Are we finding the right organisms there? And that's, again, it's more challenging when you're taking the sample from an area where you have a known microbiome. In other words, if I sampled 100 people's urine and they didn't have a urinary tract infection, I would find microbes in their urine. We used to think urine was sterile because cultures basically didn't grow anything. And so people made the assumption, well, urine must be sterile. Well, it's not sterile. We have a microbiome in our urinary tract. In our mouths, we have a microbiome. In our sinuses, we have a microbiome. In our gut, we have a microbiome. If we
There's
didn't
actually been
have,
a liver microbiome has been discovered.
yeah, yeah. So it plays a role. So the challenge becomes in terms of specificity and interpreting our results. But I tell physicians that rather than getting a negative report, or many times which were used as a secondary. In other words, they'll do culture technique, they'll do antibiotics, and it doesn't work. Then they'll send the sample to us and say, oh, aha. A classic example I use is a guy with a prostate infection that had went to 4 urologists and had 20 something cultures done. Been on many rounds of antibiotics. And most physicians, if you look at the literature and say chronic bacterial prostatitis, they'll say, oh, it's caused by E. coli, and the standard of care is ciprofloxacin for 6 weeks. So they put these poor guys on 6 weeks
Wow.
of Cipro because you have to penetrate the prostate tissue, which is difficult with antibiotics. But that doesn't mean that they're literally making this assumption based on years of culture data. I had a case of a man who had suffered through this for years, 4 urologists, 25 cultures. He went to a new urologist who said, you know what? I'm going to do something different. I'm going to send your semen to MicroGen. I want to see what they find in your semen. He got the results back. He couldn't believe it. It wasn't E. coli. The dominant bacteria in his semen was a bacteria called Fingoldium magna. It's an anaerobe. Anaerobes don't grow very easily. And so most physicians are never going to see anaerobes on their reports because the culture labs have these are essentially bacteria that grow without oxygen. And so versus aerobic bacteria. And so he had a dominant anaerobe, and he said, this is really interesting. All the antibiotics you've been on cover E. coli, which we think is the most common cause, but you've never been on an antibiotic that covers this species of anaerobe. So he switched him to clindamycin, and he told me he had him come back to his clinic in a week. And I said, that's really a short time period for clindamycin to penetrate the prostate and to have a clinical outcome. But he said, no, Rick, I had him back in a week. And when I opened the door of the clinic room, he literally jumped off the bench and gave me a massive bear hug and said, thank you for
Oh
the first time I'm feeling
God.
better.
Yeah.
So we identified the right bacteria. He got on the right antibiotic. And then when I left his office, I thought, this is really interesting. Does clindamycin have that much penetration into prostate tissue? And a Google search, and sure enough, clindamycin has really high tissue penetration into prostate tissue. And that's all it took is the identification of the right bacteria causing his infection in the right antibiotic. And literally within a week, after suffering for literally almost 2 years.
So
And
the culture techniques and protocols for identifying anaerobic versus aerobic bacteria, correct me if I'm wrong, but are different. So if they're looking for E. coli, which is an aerobic bacteria, it grows in the presence of oxygen. They're doing that culture with oxygen there. So the
yeah,
entire other category of anaerobic bacteria it's impossible to detect, even if they're there. They won't grow.
yeah,
They're
yeah,
dormant
yeah,
essentially.
yeah. Or mycobacterium is another common. We're seeing more and more mycobacterium. This is a result because South America, and as we have more immigrations coming up from the South, they're bringing more and more mycobacterium in, and that is a very slow grower. It literally will take weeks for culture methods to identify it. We've had case reports to the ASM, American Society of Microbiologists, showing where literally patients walk into urgent care centers with an infected hand. They think, oh, this is caused by normal skin pathogens. We'll give you two antibiotics because this will cover what we think. It's this
It's
empiric
a
approach.
guessing game.
Yeah, we don't know what's there, but we'll cover you with two antibiotics. And they sent him on his way. 2 weeks later, he came back. His hand was worse. They said, oh, they must have been the wrong antibiotics. So we'll switch you to doxycycline, a third antibiotic, and stop the other two.
Well,
Another
and
two
what
weeks.
and just sorry because I'm so it's so upsetting for me to hear this and to have a conversation about this. I mean, I know this. I've been in the medical field for decades, right? But really having a conversation and highlighting the damage that my colleagues are doing by indiscriminate prescribing of these antibiotics is incredible. I mean, we haven't even talked about how it wipes out the gut microbiome
Yeah,
when you're doing all that, and it has all these other downstream problematic effects in terms of chronic diseases and acute diseases that they can cause, side effects, and none of that's being addressed, and all of it can be avoided. And I'm sorry to interrupt you, but
no.
it's so disturbing to me.
Yeah, it is. Even the average layperson, the non-medical, when you explain to them the difference, they're like, why wouldn't everybody do this? This makes total sense. I mean, to go finish the case report of the poor guy with the hand infection, the next visit was not back to the urgent care, was to the emergency room. And he had a massive abscess now in his hand. So now he had the emergency room visit. They had to admit him to surgery to do an incision and drainage. So he had surgery done to open the abscess up and drain it. They took multiple samples, sent it to their micro lab at the hospital. Now, the minute you've been on antibiotics, as you know, the culture technique is now almost useless because it relies on growing. And once you're on antibiotics, it doesn't grow anything. And that's exactly what happened. Nothing grew in the petri dishes in the lab in the hospital. They sent the samples to us, and in 3 days, we had the identification of mycobacterium. None of the antibiotics he was on were covering mycobacterium, and that's what he needed coverage for. If they had simply done our tests from the very beginning, they would have avoided 4 weeks of the wrong antibiotics, an ER visit, a surgery, and a hospital stay, all because they didn't have the right diagnosis and the right
I mean,
bacteria.
all that suffering, let alone all the extra expenses
Yes.
to the medical system and the patient and their family, all of that. Well, you talked about how essentially the culture and sensitivity method of identifying the infection, that it's a coin toss in many cases. So, what is the specificity and sensitivity of your technology?
It's going to be in the 90 percentile based on the site of infection. It's in certain sample types, it's less like a pleural fluid. That's obviously the area around your lungs. That's has like a 95% culture negative. We have probably about a 40% sensitivity.
And
So
by culture negative, just so everybody understands that means that 95% of the time it will come
nothing
up
grows.
negative when they try and grow something, even
Yeah.
though there is something there.
There. Yeah. They have other biomarkers, whether it's gram stains or elevated white blood cell count. They have other markers indicating that there's an inflammatory response. The patient clearly has an infection, but nothing's growing. And so we also, in some of those cases, have a lot of negatives. So our sensitivity and specificity does drop, but it's still 4 or 5 times higher than the culture technique is, which makes it much more valuable than
And in other
imaging.
fluids, your sensitivity and
Very
specificity is
high.
even higher,
Yeah.
an 80, 90 plus
Yeah.
percent.
Yeah.
In terms then of other conditions, I mean, one of the things that when I met Ruth Chris, a nurse who was at your booth at the conference I was speaking at, she talked about interstitial cystitis, and I've treated a couple of cases of interstitial cystitis in the past, and they are notoriously difficult. And she explained to me about how clinically your testing technology is being implemented to finally get these results for interstitial cystitis, that it really there is an infection going on there, which most of the time, and you look conventionally, it's not considered primarily an infection,
Yeah.
but because the infection is not being detected. So you're detecting these organisms in the bladder in these patients with interstitial cystitis. And once that can be treated, then the results that they're not, don't typically get, it's considered a chronic problem. It can be treated effectively now.
Yeah. And I think many women, many patients are put into this category of IC because I've sat through a lecture at the Texas Urologic Society meeting years ago, and they had a speaker on talking about IC and the diagnostics of criteria for IC. It's two negative cultures. And I'm thinking, that's ridiculous. Cultures are negative all the time. And that's what you're using as your criteria to put this poor woman in this category of IC. We actually did a study with some of the top opinion leaders in IC at Wake Forest and University of California, San Diego. And what we found is that these were patients that were categorized as IC. They had culture negative. And when they sent the urine samples to us, we found known uropathogens, Klebpneumo, E. coli at high levels in these patients. They simply wouldn't grow in the traditional culture methods. The challenge you have with these patients is that often they're so delayed in the diagnosis that the more time you give the bacteria, the more time they can penetrate into the bladder wall. They can create biofilms, essentially communities of microbes that fend them, that they have one single goal in mind. That's to survive. And so they're very adept at building matrices around themselves and preventing white blood cells from basically killing them, preventing antibiotics from killing them. So we can help uncover them and tell you who is there. Then the challenge is trying to eradicate them, and that's where whether it's using Ruth is a big believer in biofilm busters and things that will actually break apart the communities. And then once you start to break it apart, you get literally shedding off of other microbes that were deeper in the mix. So we will actually see a change in the detections that we're finding as the treatment's going on. But it does take, a longer time to actually cure these women because, they're literally they've given the bacteria or fungus a head start. And so it's we can help detect it, but then you have the challenge of eradicating them.
And in terms of eradicating them, how do you then determine what antibiotics an organism is sensitive to? Is it still the traditional, sensitivity, culture
No, we
sensitivity
do
method, or
we do a better what you've described earlier in plating and zones of inhibition is phenotypic sensitivity. We do what's called genotypic sensitivity. So I think it's even better because I often tell physicians when they say, Rick, you're giving me the identification of the microbe, but I need my phenotypic sensitivity. I said, let's first of all, you only get phenotypic sensitivity if it grows. So if nothing grows, you didn't get any sensitivities because they need something to grow. With genotypic sensitivity, we don't have to grow it. The reason why the bacteria are able to be resistant is because they acquire genes that essentially inactivate the antibiotics. And so we have validated 17 different genes covering most of the classes of antibiotics. So we can tell you your patient sample has resistance to beta-lactam antibiotics, carbapenem antibiotics, Bactrim, cephalosporins. We have almost most of the classes covered. So we can be able to tell you, yep, in this sample, it was E. coli, but it also has beta-lactam resistance and it has aminoglycoside. We're actually getting ready to publish some evidence. I have more than 200,000 urine samples in my database. And I look at these reports for years, 10 years now, and I am shocked, especially with women with chronic and recurrent UTIs, the amount of resistance that we're finding in their samples. It's 4 or 5 classes of antibiotics. I don't see it in any other patient sample. I don't see it in wounds. I don't see it in orthopedics. I see a little
Interesting.
bit more in sinuses, but urinary tract by far.
Why
And
do
the
you
reason
think that
why is
is?
that?
Do you have any?
Because they're shotgun, they're hit with empiric antibiotics, one after the other.
And so
And
the ones that are still there that survive have that resistance, and then they multiply,
yes,
and they become the predominant bacteria. And so you've got this broad, this wide ranging resistance to different antibiotics.
yeah. And the whole, if you look at antimicrobial resistance, the whole AMR, they believe it's going to kill more people than heart disease and cancer in the next 10 years because we're running out of antibiotics because we keep
Yeah.
using them blindly without knowing what we're treating.
That's a very common known issue with otitis media, middle ear infections in children, and adults will take their children to the pediatrician and want an antibiotic right away, even though pediatricians
It's
understand that,
virus.
yeah, that
Yeah,
the most infections initially are viral,
yeah.
and they'll then become bacterial. And so, but they still prescribe it, and they had been for many years. And now the recommendation, it's unambiguous now: do not prescribe antibiotics at a first presentation of otitis media unless there are other symptoms that could indicate that it's a bacterial infection. So, and it's similar across the board, where I think clinicians are, they're rushed for time. It can be challenging to have those conversations to try and tell a patient, let's wait, or they want to help the patient calm down, and so a lot of times they'll just give in to what the patient wants. And now with negative reviews available, people can give their doctor reviews. I've even talked to colleagues of mine where there's concern about that. Like they don't
Yeah,
want it to negatively affect them if they don't do what a patient asks for.
yeah,
And in a way, your technology also complements and fills that need where it's like, okay, hold on a sec, let's
yeah.
get some answers first. Let's send it out for a test. Um, Now it sounds like currently it's cash only, which,
No, we went to the government, CMS, Medicare,
yeah.
years ago, and we actually it took us 3 years through subcommittees, both at the AMA and at CMS, but we actually were awarded our own code. So
Oh,
Medicare
great.
Medicare reimburses us at $354. So if you have Medicare, we don't charge the patient anymore. We charge whatever the allowable rate is, and so your test will be covered. The sad part is that the government has allowed these private plans like Humana and Aetna to sell Medicare plans as Medicare Advantage. They really should be called Medicare Disadvantage. Even when my mom was alive, I said, you are not giving up your traditional Medicare. Do not fall for this. You'll get free dental and eye with this signing up for your Medicare with Humana or whoever, because they simply don't pay us. They basically, even though we have an approved code through CMS, they ignore it and they basically deny our claim. So when our claim is denied, we essentially legally have to bill the patient, and we discount it to 249. So, but United, when I audited our United claims, surprisingly, 70% of United claims were paid. So it really depends on your insurance. If you have a good plan, then we'll file a claim, and if we get paid, great. There'll be no cost to you. Or if the plan says patient responsibility is $75, then we'll bill what the insurance says we have to bill you. But a lot of them that do deny it, we will quickly in 45 days say, okay, we're not going to wait any longer. We'll discount it to 249 and send the patient an invoice.
It is such a tragedy of our healthcare delivery system and the financial, kind of model on which it's based. And we're all consumers at some point. We're all sick, or we have kids or spouses. Somebody is going to be in there. And I have health insurance through I won't say who the provider is, but a very large national provider, and it's basically worthless to us
Yeah.
unless one of us, God forbid, gets in a car accident and ends up in the ICU.
Yeah.
Other than that, for
Catastrophic.
any integrative medicine even just going for to my wife to the gynecologist. Even we end up paying out of pocket for that as well. A
Yeah.
part of it.
Uh-huh.
So it's a sad situation that people have to navigate, and I'm happy to hear that you've really done the work to advocate for patients and also to help expand the impact that your technology and your company can have, because the more people are covered by insurance, obviously the more the testing will get ordered and people will finally get the results and the healthcare that will finally help them. But at the very worst, it sounds like there could be some out of pocket, and hopefully for the vast majority of people, that's an acceptable expense to hopefully get the answers and stop what for many people is years and years of suffering.
Yeah, if we can get your listeners to actually the woman that had our technology used our test and had her chronic UTI solved and resolved. She was so happy, but she said, she fought with her insurance company. She called me. She said, "Rick, this is just wrong. They should pay for this. It helped me. It actually made the difference. It saved them money from repeat visits and repeat rounds of antibiotics." Um, and I don't understand it, but she's actually started a petition drive that I was never aware of, that you can actually, there's a mechanism. And I was shocked. I think she has like 38,000 people have signed her petition. And what the petition says is that if a woman with a urinary tract infection has gone through standard of care of traditional cultures and antibiotics, and it fails, the AUA, the American Urologic Association, needs to support the use of microgen or molecular technology to identify the problem. And it's a simple ask. It's not saying replace cultures. It's just saying use your cultures, use antibiotics, but if it doesn't work, don't keep doing the same thing over and over
It's
again.
asking for a phased approach. What
Yeah.
do you happen to know the URL for that or the name of it? I'd love to be able to
I
share.
can get it for you through James, our marketing people. I'll find
Great. If you
the
pass that along, we'll put it in the show notes. Absolutely. Anything else you want to share with listeners about MicroGen DX, chronic infections, what you all are doing?
I would just say that, I talk to a lot of physicians. I'm on the road. I do a lot of presentations to physician organizations, and I often tell the physicians that if you're skeptical and don't believe this, one, try it, compare. But I said at one point you're going to have somebody in your family, a loved one, that's dealing with a serious infection, and you're going to want this technology. They could be in the ICU with a ventilator-associated pneumonia that they can't figure out. They could have a chronic wound that won't heal, or it could be, I've actually had physicians come up to me saying they were an orthopedic surgeon. I was talking to them about joints, and they'd come up to me on the side and say, "I've been dealing with a prostate infection for the last 6 months. I want to be able to use your test." So,
Wow.
it can help a lot of people in a lot of different types of infections, and so. If you hear somebody that a friend or loved one that is dealing with something like a chronic infection, let them know. Just tell them, hey, there's a better way to help identify what's causing the infection.
Well, and the name of your company is so intuitive and it's easy to remember. MicroGen DX.
Yeah.
Infection, MicroGen DX.
Yeah.
That's where my mind is connecting the two now, and
Yeah.
hopefully other
Yeah.
people will
Yeah.
as well after hearing this. Last question for you, because I am curious, how did you get involved in this?
Yeah, I worked for the big pharma. I worked for Pfizer for 19 years, and I was an Army officer in the late 80s, and I left the military, and at the time Pfizer hired a lot of military officers for their sales team. And Pfizer was a lot smaller back in the 80s, but it had a division that sold their antibiotics and their antifungals. So I was in that team, and I had to learn very early on how to talk to infectious disease doctors at their level and dialogue with them and have good evidence. And that's where I've been so focused on evidence, because I learned early on, if I don't have really good evidence, they're going to eat me for lunch.
Yeah.
So I left Pfizer, and I met the founder of the lab, Dr. Walcott, and he was heavily involved in chronic wounds. He literally would have patients travel all over the US to Lubbock, Texas to see his wound care center, because he was applying this technology. He was using molecular DNA analysis of the wounds to pick the right antibiotics and apply them topically. And his healing rates were amazing. I mean, they were literally 90% by doing this approach. And it makes sense if you're trying to heal a chronic wound that's loaded with bacteria or fungus, oral antibiotics and IV antibiotics don't penetrate the biofilms in these wounds. So anyway, Dr. Walcott and I started working together, and he had a difficult time convincing physicians on how to use the technology. I said, well, that's kind of my background was, in sales, was talking to physicians. So I think I can help you. And so we started working together. And then in 2017, I asked him what he was going to do with the lab, whether he was going to eventually sell it to Quest or LabCorp. And he said, I would never do that, Rick. They would shelve it. They would take it off the market. But I'll sell it to you because I think you built this company, and I think you're in the best position to help us make sure that patients have access to this technology. And so, Randy's a very passionate guy. Everybody always says it's about the money, but with Randy, it wasn't about money. It was about his research and doing the right thing for people. So,
It's a great story, and it's amazing too to understand that you were, in a way, colloquially speaking, you've become part of the DNA of MicroGen DX. So
yeah,
it's
yeah,
been great talking to you. I've learned a ton. Tell people about your website, how they can learn more about your technology and your company.
yeah. It's MicroGenDX.com. Very simple.
Very intuitive, very simple.
MicroGenDX.
All right, and that'll be in the show notes as well. Thank you so much for spending a little bit of time with me.
Yep.